Hi, it's Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County, with another Facebook Live. It's Tuesday, July 14th, and we'll get started. I'm sporting the newest looking balaclava to have the ear loops. I'm not quite sure these work, so I'm going to take this down here so that people who read lips can read my lips. Again, Dr. Bob Dannenhoffer, July the 14th. So this is your time to ask questions. So we're on Facebook Live. Please put them in the comments, and we'll try to answer the questions. Last time we had a few questions that were a little obtuse, so this is the time to answer Facebook questions. I'm not very good on recipes and other things. So let's start as we usually do with how things are going in the world, and the answer is not so well. 13.5 million cases and 580,000 deaths, and this is worrisome because both the case rate is increasing and the death rate. So for a while there, the case rate was still climbing, but the death rate was going down, suggesting that overall these were more lower symptomatic cases and whatever. But now the death rate is going up, and that is a big concern. We're seeing lots of cases still in the U.S., Brazil, India, and Russia, and still seeing enormous cases in Chile. Chile has the highest attack rate of anywhere in the world, and you know Chile is a fairly advanced country in South America, and that is worrisome. The other thing we're seeing is a big outbreak in South Africa. South Africa, remember, Southern Hemisphere has opposite seasons as do we, so they're just in the height of their winter, and they're really having a lot of cases. So many cases just today. So we worry about that for what that means for us when we start to get cooler weather. In the U.S., we're at 3.5 million cases and 140,000 deaths by the end of today. That's a lot of cases and a lot of deaths, and it continues. It peaked over the weekend. It's slowed down the slightest little bit over that time, but I see today Florida had its highest death rate, and still lots of cases in Florida, Texas, Arizona, Georgia, Louisiana, South Carolina, and California. Really is problematic. In the state, we continue to have the average 300 or so cases a day. Again, the cases seem now to be mostly in the Portland area, in the Columbia Gorge, and especially now in Malheur County, where they've had an enormous outbreak in Malheur County, mostly centered around the prison, but in other places in the county. As we look at the daily outbreaks in the state, you can get a chance to see what's going on. And now we're seeing what I feared before, was that some of the community outbreak among young people is now spreading to nursing homes, and there are a bunch of cases in nursing homes and other long-term care facilities today. So that is a bit of a worry. There were a lot of deaths in Oregon today, although I will tell you that the death notices are frequently somewhat delayed because we want to be sure we have every detail right before we post a death notice. In Douglas County, we're adding 2 or 3 cases a day over the last few weeks. Some of these confirmed, some of these presumptive. Now again, let me explain what the presumptive cases are. The presumptive cases almost certainly have the disease. They are in a family where there's somebody who has a positive COVID test and they have exactly the COVID symptoms, or they have the COVID symptoms and have a positive test, but not yet a confirmatory test. We've yet to find a single case in the presumptive things that in the end you wouldn't consider a case. So although we break out the presumptive and the confirmed numbers, some people suggest, oh, the presumptives are just guesses. No, these are really probably people who have the disease. So we've had that. And Douglas County had its first death earlier this week. It was a person who was from Douglas County, visited another state, got sick in the other state, was hospitalized in another state, and died in the other state. Because the way we count things, we count where people are from rather than where people specifically die. So if I go to Hawaii and die of a heart attack, it doesn't get counted in Hawaii's statistics. It gets counted in the Douglas County statistics. Not unreasonable, since I spent most of my life in Douglas County and have the risk factors from Douglas County. It's imperfect. For some things we can also count by where they died and where they lived, but it usually doesn't change things very much. It could, for example, if you're looking at something very specific like scuba diving accidents, and, there are people probably from Nebraska who go to Hawaii and die of scuba diving accidents in Hawaii. So for something very specialized like that, you might look at both place of residence and place of death. But since people move across borders, we've not yet done that with COVID. Let me go through a couple of other things and then we'll get there. One of the things that did come out this week was from the CDC. The CDC, our Centers for Disease Control, they're supposed to put together the statistics. And every couple of weeks they come out with another distillation of the data as we get better. So a few weeks ago, you remember, I talked about the symptoms that the CDC said were associated with it. They had a really nice graphic. 2 weeks ago, they came out with a graphic about what diseases put you at higher risk. I really like that one because you could look at the disease, you could look at what the risk was, and then you could actually look at the source of the data. They came out this week with their recounting of what the disease is and about symptomatic rate. They thought about 40% of the people are asymptomatic. That's not surprising. You remember back in the very first time we did this, we talked about the cruise ship, the Diamond Princess, and at that time we said that between 20 and 40% of the people appeared to be asymptomatic. So they think 40% is asymptomatic, which is right in that range. The second was the reproductive number. So if everybody gets the disease and you didn't do anything, you didn't socially distance, you didn't do anything else, how many other people would you spread it to? And originally we predicted it would be somewhere between 1.7 and 3.4. That's really high. Flu is just a little over 1. There are many diseases much less than 1. So 1.7 would have been high. 3.4 would have been astronomically high. I think they've settled on 2.5. And then the last one is the infection fatality rate, which we've talked about a lot. Took everybody who had the disease, what percent of people would you expect to die? And we've had estimates anywhere from 0.1% to 2%. I thought it was going to wind up somewhere between 0.5% and 1.5%. They predict it's 0.65%, so 2/3%, right in the range that we suggested. Okay, so we're going to go ahead and answer some questions. I have more stuff here if we have time. It's a little higher so you can hear me better. Put right in my balaclava. How's that? Is that better? Okay. So Kathy says, are people getting this twice? We do not think so. Now, there are a couple of cases where people had the disease, they got over the disease, they had negative tests, and then later on they got mild symptoms and tested positive again. Most specifically, this was on the Teddy Roosevelt, where they had about 13 people who had this scenario. Had the disease, over the disease for several weeks, 2 negative tests, come back on the ship, get sick again, get tested, and have a positive test. So yes, they would be getting this twice. None of them appeared to be very sick. But again, on the aircraft carriers, mostly young, healthy people, so we don't know. We're going to know this in the fall when the disease starts to spread again in areas like New York and New Jersey. There will then be people who had clearly positive tests early on, were symptomatic, and then we'll see what happens the second time. And there are 3 possibilities. The possibility which is least likely, but happens with some diseases, like dengue, is that the second time you get it much worse. I don't think that's going to happen with this disease. The second possibility is that you get it just like the first time. And the third possibility, which is most likely, is the second time you get this, you would be less sick. That's typically what happens with most respiratory viruses. The second time you get it, you have a little bit of immunity and you don't get as sick again. So Catherine says, it's so sad about the individual who died who contracted the virus. We have not finished the investigation yet. You can imagine it's really, really hard to do an investigation when somebody's just lost a loved one, especially so tragically. And so we're still working on that to figure out where the person contracted the virus. So that's something we will figure out with time. But you can imagine after death, there's so many things going on. And talking to public health is maybe not top on your list. And since it doesn't really change anything, Serena asked, could wastewater transmit the virus? We do not think so. So we clearly know that you can find the RNA from the virus in wastewater. And a lot of people have done innovative studies where they've sampled wastewater looking for the RNA of this virus. And they are very good at that, at predicting where this virus is circulating unknown. This is really amazing that we can do this, where you can sample wastewater, look for the RNA, and say, I'll bet you there's disease there, and they're right. We do not think, though, that these are whole viruses. We think these is just fragments of DNA, RNA, so we don't think it's transmitted through wastewater. So are those that are surviving not having underlying conditions? So when we look at our cases here, we think they have exactly the typical distribution of underlying conditions: asthma, obesity, high blood pressure, COPD, and whatever else. And so we don't think that this virus is specifically attacking people with underlying conditions, but we know that age and underlying conditions, especially multiple underlying conditions, are going to clearly increase your risk for severe disease and death. Yeah, so Carol says, how can I get a CLIA certified test with results within 72 hours of travel? That's really hard. So the turnaround time on tests, which is you do a test, how long does it take you to get it back? Initially was very long, a week or two, really unacceptable. It got down to the point where it was just a day or two. So, we were doing these clinics on Tuesdays, Fridays, and Saturdays, and frequently by Friday, all the Tuesday tests would be done, and by Monday, all the Friday tests would be done, and sometimes I would do these on Saturday, and what I would check on Monday, they would all be done. So we were down to a turnaround time of 1 to 2 days. Now it's really long. We've done a bunch of tests. We did a bunch of tests on 3rd for people who had positive antigen tests, but we're looking for confirmatory PCR, and we're still waiting from those tests from the 3rd. So this is a really long time. So the regular testing strategies that we used before, where we used to be able to predict that, you can't do that now. So where could you do it? So there are some rapid antigen tests. I do not know if the rapid antigen tests count in every state. Somebody asked me this question yesterday, and I had to look it up, and it didn't count in the state I was looking for, but an Abbott test would. So this is a hard one. I don't know a great answer. Depending upon let us know which state it is, and we'll figure out if there's a way we can get that done. So Stacy says, are churches opening? Well, I don't think churches were ever closed. I think the size of indoor gatherings was limited. And so the size of indoor gatherings were limited. Churches are considered like other venues. They can be open, but you need to have adequate spacing, and there's a limit to the number of people you can put in them. So churches are okay, although we do know that churches are somewhat of a risk factor. When we look at super spreader events, that's events where one person spreads it to a bunch of people. Churches and bars seem to be way overrepresented. And it's probably because in churches we go for a long time. It's not like you could just go for 5 or 10 minutes. You can usually go for an hour or more. These are your friends and neighbors, and you hug them and get close. The thing that what happens with churches is there's frequently a lot of singing, and singing we think is a risk factor. So churches are open. There are no new limits on churches. So Linda says, could you explain isolation? And so isolation means that you're a case or a presumptive case, so you very likely have the disease, and you are potentially contagious. So we know if you have the disease, you're usually contagious for 10 days after the onset of symptoms, 10 days after a positive test, or 10 days and your symptoms are improving. So isolation means that you are at least 10 days from the onset of symptoms, at least 10 days from your positive test, and your symptoms are improving. The question is, do you need a negative test for release? No. A negative test for release, we have found, is really, really, really problematic, because a negative test, there's some people test positive for months thereafter, and we don't think they're contagious. In fact, we have tried to find a case where somebody has a viable virus. It's a virus that can infect somebody else after the 9th day, and we've looked in the literature and cannot find a case. And so a negative test for release is problematic because it doesn't really add anything, and in many cases stays positive for a while. And so we have a bunch of people who've had positive tests after they're better, and they can't go back to work. And we think that's unfortunate because they can't go back to work, and we don't think they're contagious. So we do not require a negative test for release. We would not recommend a negative test for release. There are some businesses that want a negative test for release. We think they just haven't read the literature yet. So should start testing employees. So really what we should do is we should have a tiered structure towards testing. The very first people we should test are sick people. Sick people who have symptoms like COVID should all get tested. And we know that right now a lot of people aren't getting tested, even though they're sick. So the first is sick people should get tested. The second is even mildly sick people who work with high-risk people, nursing homes, hospitals, other kinds of things. The next would be, if you're going to test asymptomatic people, it would be asymptomatic people who are contacts of symptomatic people. And then after that, it would just be asymptomatic people like employees and whatever. It turns out that testing materials are tight again, and it really doesn't make sense to test asymptomatic people until you have enough tests to test symptomatic people, because symptomatic people are at least 10 times and maybe 100 times more likely to be positive than asymptomatic people. Think about it. How many times, how many days in a year would you have COVID, have symptoms similar to COVID, cough, fever, whatever things? Probably for me, it's only maybe 5 days in the year, which means 5 days of the year I'm symptomatic, and 360 days I'm not symptomatic. And so the chance of catching the disease is about 10 or maybe 50 times higher on the days that I'm symptomatic than the days I'm asymptomatic. So if we had plenty of tests, if they're easy to do, just spit in a cup, then yes, we should start testing asymptomatic people. We have found, though, in this county that testing asymptomatic people has really not been very useful. We've tested well over 1,000 asymptomatic people in other places, pre-employment, pre-surgery, people traveling. We haven't found a single one positive. So they're very, very, very low yield. And so I think testing healthcare employees, I don't think that's very useful. And I will tell you, all the other countries that have gotten this under control have not done that. So Debbie says, how is COVID going to affect schools? Well, I wish I knew. So I was on a call with the governor today. I usually don't report. So the governor says, well, does anybody have any input on reopening schools? And I said, the only two words I said in the whole conference, and I said, it's complicated. Because the answer is, it's really complicated. And it's complicated because schools do such positive things. I mean, they teach our kids. When the kids are at school, parents can work without getting daycare. When kids are at school, a lot of kids in Douglas County, a lot of kids in the country get free lunches, so they get fed. There's a great school-based health center in Roseburg, so people get health care. Kids learn. If they're out of school for 6 months or a year or 2 years, what's going to happen to the achievement of those kids, especially for those families where the parents themselves struggled at school and may not be the best teachers. So there's a lot of positives to opening up school, but on the other hand, there's negatives. You're putting a lot of people together, and you're putting a lot of people in a close area. In many cases, you're going to be driving to school on a bus and thus having kids in an area here. Many of our teachers are older, and teachers love their students, but they don't want to get sick from their students and get this. I have gotten so much really, 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 really emotional email about this. And my point is, we have to really look at the facts. Let's not get emotional. On the one hand, somebody said, if you open schools and people die, it's blood on your hands, Bob. It's like, and then not 10 minutes later, as chance would have, I got an email that if we didn't open schools, that it was going to be so detrimental to society that society would fail and the failure of society would be on my hands. It's like, what do I do? If we open schools, the blood's on my hands, and if I don't open schools, it's the failure of society is on my hands. And the answer is, it's probably neither. And really, I really don't have that much authority. The good news is that other places have opened up schools. So Denmark, France, Israel, New Zealand, Australia have all opened up schools, and they've not had lots of problems. There have been some infections, but there really have not been a lot of outbreaks. There have not been deaths. So they've done this pretty well. However, you'll look that when they opened schools, they tended to have a very low infection rate. So one of the ways we look at the infection rate is the number of new cases per 100,000 residents per day. It's relatively easy to calculate. And in New Zealand and Australia, they had less than one new infection per million people, so less than a tenth of an infection per 100,000 people. So that would mean in Douglas County, one infection every 10 days. When they opened schools, they had no problems. In Europe and Israel, they opened schools when they had about one or two new cases per 100,000 a day. That's like where Douglas County was a few weeks ago, a little over one or two infections per day. And they also had no problems. Now, there were some outbreaks, but almost all the outbreaks were where parents gave it to their kids. The kids got sick, they quarantined the class, but everybody was well, because the kids don't seem to pass it very much to each other, and they don't seem to pass it very much to their teacher, which is one of the most bizarre things about this virus, because kids are usually little cesspools. I mean, they are just giving germs back and forth all along the way. So, for example, we see hand, foot, and mouth disease go around a preschool class. I can guarantee you within a day, everybody in the class is going to have it. Or when strep is in the class, you find a bunch of cases with strep or lice or any of those things. It really spreads among kids because kids are not very good about social distancing and minding their germs. But this is different. This is really different. I mean, I didn't believe it in the beginning because it was so striking. But this really doesn't seem to spread among kids. So I think we could probably open schools safely if there was enough space, if we got teachers who were comfortable to go, and if we had the baseline rate down to one or two new infections per 1,000 per day. So to give you that idea, Douglas County is a little bit above that. The state is 10 times above that, and the country is 20 times above that. So in a place like Florida, where you're having 30 or 50 infections per 100,000 people a day, starting school in those areas means the school's going to be closed down the whole year. So I don't know what's going to happen. I am on the governor's Healthy Schools Reopening Task Force. We met for hours last week. We have a 4-hour meeting tomorrow. Yeah, we'll see. So Celeste says, why don't we run labs locally for quicker results? Oh, I wish we could. So these tests that are doing are really complicated tests. These are not things I could do in my backyard. They're not things I could do on the bench. You need lots of reagents and specialized equipment. There are 2 of the machines in the state, in the county, that do this. Rapid testing, the Abbott ID now. There's one at the Cow Creek and one at Mercy. We've been trying to buy more. They're just not available. And then Nova has an antigen test, which is a different kind of test, which also seems pretty good. Boy, this is a problem, not having these things. These are not things that the local lab can actually do, the fast ones, which are the bench tests, and this is a big problem. So Chip says, what's the chance that any vaccine will not have long-term coverage? Well, so vaccines go anywhere from lifetime immunity. So measles vaccine gives you lifetime immunity almost always. There's some vaccines which we know don't give you very long immunity, like the influenza vaccine, and that's why we do the influenza vaccine in the fall, so it'll cover you in January and February. We don't know. I think there's a chance we won't get the vaccine. There's a chance that we'll get a vaccine, it won't be very effective. There's a chance that we'll get the vaccine and it'll have some side effects, and that people will be worried off by the side effects. And then I think the biggest risk is that we get a vaccine and that we get what I call the true, and unrelated. So if on December 1st you got the vaccine and December 15th you won the lottery, most people wouldn't say, I won the lottery on the 15th because I got that vaccine on the 1st. But if you got the vaccine on the 1st and on the 15th developed a stroke for the first time, you'd have to look back and say, well, I was fine. I got this vaccine on the 1st, and now I got a stroke. Well, in this world of the internet, if you posted that on Facebook, like within 10 minutes, somebody from Nebraska would say, that happened to me too. I got it on the 1st, and on the 20th, I got a stroke. And then other people would say that, and then people would say, oh my God, maybe this gives you strokes. Now, it may be that I was going to get the stroke anyway. It had nothing to do with the vaccine, because people at my age, those kind of things do happen. And so it's possible that it would be that, but it would take a long time to go ahead and dispel that. So for example, with measles, mumps, and rubella vaccine and autism, clearly kids got measles, mumps, and rubella vaccine. Clearly kids develop autism in that second year. There's no question about either of those things. And the question is, was the autism from the MMR vaccine, or was the autism something that was going to happen anyway? And I think they've done beautiful, elegant, long-term studies that show that the MMR and the autism are not at all related. But it took 10 years, millions of dollars, and lots of cases to prove that. And the only way to prove that is you look now at the kids who get autism who didn't get the MMR vaccine. And did they get the autism at a different rate? They got autism at exactly the expected rate. And thus you could say it was not related to the MMR vaccine. But in this, where we're going to do this quickly and want to get everybody vaccinated quickly, this true and unrelated thing is going to be a problem. But the good news is that they're making good progress on the vaccines. There's about 20 vaccines out there that are in human trials, that are 4, I think now, that are in phase 3 trials, which is a bigger trial. So I think this is good. So will middle school and high school return to school as cohorts? So I don't know the answer to that, but let me explain how cohorts work. So I got a call today from the school principal. I said, what the hell are cohorts? What are you going on here? And so I said, well, if you're in a class for hours and hours with other kids, you're going to expose all those other kids. And so if one of the people in that group got the disease, all of the people in that room would be contacts, and they'd all need to be quarantined. So if you were able to have cohorts as small as 10, like we did for summer camp, and there was an outbreak, those 10 kids would have to be quarantined. But let's say you didn't do it in cohorts, so the kids rode bus 6 to school, before school were in the cafeteria with these 11 kids, then had had school with these 12 kids, then had lunch with those 30 kids, then went to art class with a different 20 kids. If one of those kids got it, all of those kids then would have to be quarantined, and the school would likely have to be closed down. So the story is, if you could do schools with small cohorts, each cohort would be much less likely to get infected, and the number of kids who would get excluded from school would be very, very low. I don't know how you do middle school and high school as cohorts, right? Because in high school, we expect to go class to class. We expect to have different teachers. We expect not to be in the same class with kids all the time. So cohorts is one of the ways to do it. I think I use vernacular terms all the time. I think what it is a one-room schoolhouse. So if you think of the one-room schoolhouse that's out at the Melrose School there, kind of cute. Little room, probably a couple of 100 square feet, maybe 8 or 10 kids that would be with that teacher and that one teacher all the way through. And that's sort of what cohorts would be, is a small group with the same kids all day. I don't know if you can do that in high school. I don't know if there's any of us that's smart enough that we could teach every subject in high school. And I'm not sure that kids in high school want to be with the same 10 or 12 kids all day, but that certainly is a possibility. So how does the COVID infection and death rate compare to the flu? Great question. So the flu, and we're talking about influenza, causes about, they say, if there's 2 ways to look at this, 50 or 60,000 deaths a year. Those 50 or 60,000 deaths come from a small number of people who actually have confirmed disease, and then they look at the excess deaths that occur in people who would get the flu in those areas, and that's how they calculate that 50,000 deaths a year from the flu. If you said the number of people actually had flu tests and died of the flu, the number is only 6,000 to 10,000. And so when we look at COVID, where we're only doing it in people who have a positive test, the death rate is 20 times higher from COVID than the flu. So 20 times more deadly than the flu, and probably twice as contagious. So again, the R naught for flu changes, but the infectivity of flu is usually a little over 1. This one now is 2.5. So what I tell people, twice as infectious, 10 times as deadly, overall 20 times as many deaths. And that's what we see. And that's what we see. And this really is the case. I worked at a hospital for a long time and had something to do with bed control and looking at people there. During a bad flu season at any hospital, you'd have a couple of people in the hospital. You'd have an occasional death from the flu. Look at what's happened in New York. Look what's happening in Florida, Arizona, and Texas now, with whole wards full of people with COVID and many, many deaths every day. So yes, it's like the flu in some ways. It's a virus. It's like the flu. It's a respiratory virus. It's like the flu in that it's probably mostly particulate, but it's unlike the flu in other ways. It's got a really high death rate. This has a really high death rate in seniors, much higher than the flu. This has a very low death rate in kids, much lower than the flu. overall, it's got a much higher infection fatality rate. So the infection fatality rate, everybody's infected from even the worst of flus, is no more than 0.01. This one is 0.65, 65 times as much. So, it's 65 times as deadly if you get it. It's more contagious. This is much, much, much worse than the flu. And that's why we've closed things down. People say, why don't we close down things every year for the flu? Because flu is bad, but, we've got a vaccine, we've got an antiviral treatment, and not that many people die of the flu. Yes, public health, we close it down every year, but we wouldn't also be very good politicians. So what's the asymptomatic case rate for each age group? Is it 40% across the board? Very interesting that you would say that. The CDC didn't break it out. The thought is that the younger you are, the more likely to be asymptomatic than older age. Although, when you look at the Diamond Princess, which were mostly old people, their asymptomatic rate was 20 to 40% too. And when you look at the Teddy Roosevelt, mostly young, healthy people, was 20 to 40%. So 20 to 40% seems to be in each age group. Kids may be different. I don't know. So are there any cases of the new cases due to riots in Eugene and Portland? So for those of you who listen to the news, I was on Lars Larson the other day, and he asked me about that. And I said, well, Douglas County's not had a lot of bad riots, so it's a little hard to know. And I don't know the specific cases in Eugene and Portland. My friends in Eugene and Portland say they really haven't seen that. And he says, well, how could that be? There are lots of people out there, a lot of people together. A couple of things. One is they were mostly milling about. They weren't just standing in one position. They were wearing masks a lot, maybe to hide their faces, but a lot of them were wearing masks, and they were almost all outdoors. So outdoors, wearing masks, milling about, much better than sitting still indoors. So we haven't seen any cases. I don't know if there are any cases, but when you look where the big outbreaks are in the South, these are not places that had big riots. Right, so it's not like if you said, "Oh my goodness, Minneapolis has had such a spike." Not really. New York has had such a spike. Not really. D.C. Not really. Those are three areas that have been very quiet. The places that really get it are like rural Texas, where they did not have a lot. So there could be some cases related to that. I would never say no, but it doesn't seem to be prominent. Again, for us, most prominent is travel. So somebody asked me what states. So Alaska, Washington, Idaho, Utah, California, Nevada, Texas, and Florida. Now, I'm sure there may be others, but it's like all over the place. At least half of our cases in the last month are associated with out-of-state travel. And, what is there anything about out-of-state travel? There's nothing specific about out-of-state travel. When you go out of travel, for the most part, you're in contact with people at airports and different places. When you go out of state for travel, you're usually eating out rather than cooking for yourself. When you're going in out of state travel, these are places that have high rates of disease, except Alaska, have high rates of disease. And when they have high rates of disease, you're much more likely to get it. So, for example, in Texas, in Tulsa County, so Tulsa County, which is about 6 times the size of Douglas County, remember we're having 2 or 3 cases a year. They're having 400. 2 or 3 cases a day. They're having 400 a day. And so your chance of getting it there is going to be hundreds of times higher than here. And so the problem with travel is that you're milling around in airports and doing the kind of things that you have little control over, right? So you have little control over the crowding in the airports. You have little control about going out to eat. And then there's a lot of background disease. So looking at all of these things, travel is the number one thing. The second are big family gatherings. I will tell you, these big family gatherings, and especially gatherings in bars, seem really to be a risk factor. So any updates on the mutations? Yes. So did you ask? Good question. So the 614 mutation, we're now beginning to piece it out. So the spike protein, which caused it, in the past had been connected by this tiny little thread between them, which is a little amino acid that connected these two proteins. And the 614 changes that amino acid. So now, rather than this top piece falling off easily, sticks on a little bit better. And by sticking on a little bit better, we think it's a lot more contagious. Some people have suggested it's even up to 10 times as contagious as before. That would be terrible, but that's what the mutation is. So it's a 614 mutation. So the 614 mutation, called that because it's at the 614th location of the nucleotide, seems to be taken over our country and taken over much of the world. So, yeah, that's the deal on mutations. Now, mutations can also be ineffective mutations, and so we could hope for that. But unfortunately, this mutation made it worse. Yeah. So somebody says the unofficial graffiti cruise on Harvard had over 1,000 people, most not in masks and not social distancing. Will we see a spike in a week or two? I don't know. Again, the only good news on this is this was outdoors. And so that's better than being indoors. But nonetheless, a lot of people gathering around is problematic. So once exposed, how soon would you expect to get a fever? Gail asks. So there's no, this virus is amazing. So Fauci was saying today that he's never seen a virus with so many varied presentations, and nor have I. He's older than I am. But what we've seen, and some people never get a fever, some people get body aches, some people get cough first. I think the most typical one is a sore throat and body aches on the 4th or 5th day after exposure. Sore throat and body aches are not all that uncommon, so people would get that. The next day, the body aches get worse, and you start to get a little low-grade fever and cough. The fever is most prominent on the 8th or 9th day, and then loss of smell at around that same time. But there's no one typical thing. So a number of the people who've been positive say, I just thought it was allergies and sinus congestion. I just had some sinus congestion, a little bit of cough, but nothing really bad. So the symptoms on this go anywhere from nothing to death. So it's really hard to know. So should you automatically be tested if you're exposed? So exposed would mean you were contact. And the recommendation for contacts is to test asymptomatic contacts if you have testing available. And until recently, testing was pretty widely available. And so yes, we recommended that exposed people get tested, but to get tested right away, which people are like, I was exposed yesterday, I want to get tested today. Even if you're exposed yesterday and really got it, it wasn't going to show up today. You need to wait about a week after exposure for the test to be the most positive. So Tracy says, regarding outdoor face covering mandate in baseball, should the batter, ump, and catcher wear masks? Well, I would say for a safety thing, they should at least wear their protective masks. And I've always wondered why they couldn't be changed so that there would be plastic covering the face, and that would also protect it. But yes, according to the new guidelines, they should. There was a bit of an outbreak associated here with the Doc's team. They didn't have any cases, we think, but 2 of the teams that came in had people with cases. So Judy says, what's the positivity rate of those being tested locally, and how does that compare to prior testing? So a month or so ago, our positivity rate was much less than 1. That means we'd go 100 consecutive tests in our clinic without having a positive. Now, because of the delay in getting the test back, it's a little hard to know. But the state positivity rate is up about 5%. Our positivity rate, we're doing about 500 tests a week in Douglas County. And again, with about 10 cases and 500, it's still very low. It's still 1 or 2%, but it's up from where it was before. In most of the places that have gotten this under control, they've tested until their positivity rate started at 5%, 2%, 1%, half percent, 10%. And once they got down to about a 10%, they had this licked. And similarly, we were down to about a 10% in a while, and we thought we had this licked until all these other cases come in. So we're a little higher than we were before, but still much better than others. They reported positivity rates in the South this week at over 20%. At over 20%, there's so much disease out there. Yeah, so Bruce says, have you heard about it? Increase in resting respirations being an indicator of COVID. There is a smartwatch tracking this. Yep, this is one of them right here. So I'm part of a big study that's tracking my respiratory rate to see if I get COVID. We'll see what happens. So yeah, there's a concern that this could happen. The other thing it monitors is my temperature. So yeah, they're looking to see if people had little temperature spikes, and that would be it. It's interesting that during a flu season, there are people who have these Bluetooth connected thermometers, and you can see when more people have fevers in the community, that's when you know flu is going to spread, but that's interesting. The other one is how long you can hold your breath. And so early on, the Chinese had people hold their breath And if you could hold your breath for more than 10 seconds, you were in better shape than if you couldn't. But if you can't hold your breath for 10 seconds, you're in bad shape anyway. Yeah, how well prepared is the state to withstand a second wave, as we're already short on tests and PPE? I don't know. I mean, the hope would be at this time that we would be building back our PPE supplies so that everybody would have 30 days at the local level, 30 days at the state level, and 30 days at the federal level. So we would have 90 days. Unfortunately, our PPE days on hand is going down. So that's a worrisome. And similarly with testing, that's worrisome too. Now we're told that there's going to be lots of new rapid testing coming online. I'll believe it when I see it, because there's been a lot of hype about how much testing we'll have so soon, and we haven't seen it yet. But yeah, it's a real worry. So should children wear masks when playing with friends indoors now? I don't know. I mean, kids less than 12 is really, really hard to get them to wear masks and leave them on, although I saw some of the cutest masks ever today in clinic. So I'm not exactly sure about masks in preteens. So Haley says, could you get COVID from doing a home visit with a client? Yeah. So I was in the clinic today, and there were a bunch of people there. It was a lot of close contact. We try to do as much by telehealth as possible. So yeah, if you can do it by telehealth, clearly do it by telehealth. Again, my risk of getting the disease, or anybody's risk of getting the disease, is how many people were you less than 6 feet for more than 15 minutes. And since my visits in the office are usually about 15 minutes long, they're right on the edge of being a worry. Now, I try and wear a mask. I try and, the part where I have to do on the exam, stay close, but for the rest of it, get to the other end of the room so I won't be exposed. But it's still a risk. Again, the number of people you see in a day and the amount of time you're with them is a risk factor. If you could do telehealth, do telehealth. There's so much now you can do by telehealth that I really like that. So someone says, why haven't we been encouraged to build our immune systems? I don't know, because I certainly encourage it. So the best way to build your immune system is to get outside, play in the dirt, have animals. So those are the 3 ways that you build your immune system. So there are millions and millions and millions of germs out there, bacteria, fungus, parasites, viruses, and you get exposed to them all the time. Very, very, very few of them are bad actors. In fact, most are pretty healthy. So what I tell people about germs is that germs are like a population. Most of the people in the population are pretty nice and they help you and you need them. But there are going to be a couple of bad actors out there who are going to be criminals and whatever else. You don't need to avoid everybody, you just need to avoid the criminals. Now, sometimes it's hard to tell the difference. But we encourage people to get out there and build up their immune systems by having a garden, by digging in the dirt, by being outside and doing all those things. That's the best way to build your immune system. You just need to avoid the few germs that are going to cause troubles. So, for example, most E. coli that's out there doesn't bother you at all. And we think the more exposure you have to those germs, the healthier you are. In fact, there's this whole hypothesis called the hygiene hypothesis that suggests that farm kids are healthier. And I think it's true, because they're out in the dirt a lot and they're playing with the thing and they're eating their lunch off a post where the animals just pooped in the field. That kind of stuff that happens when you brought your kids up on a farm gives great immune system. So my kids grew up on our little sort of farm-like thing, and we had horses and sheep and chickens and whatever else. My kids were never sick. And so that's how I would encourage you to build your immune system. Wearing a mask doesn't make any difference. Are we seeing any flu yet in Oregon? Not yet. And we're carefully looking, because once we get flu, it's going to be really hard, because the symptoms of flu and the symptoms of COVID early on look a lot alike, right? Cough, sore throat, body aches. So we haven't seen any flu yet, but once we do, it's going to get much more complicated. So Luann says budesonide, and I knew I would get that question. So budesonide is a great thing. So I wrote a long story today about budesonide, and I'll try and remember it here. So there's this doctor from Texas who has done some YouTube videos talking about his use of budesonide in patients with COVID-19, and it's magic. Gives it to them, 100% get better, and within just an hour or two, they say they're feeling all back to normal. That's really encouraging if true. Budesonide is an inhaled corticosteroid that we use for asthma. I've been using it for years. I can't even remember, 20 or 30 years. I've been using it for asthma, using it in even preemie babies, and I've never, ever had a kid have a side effect from it. So it seems to be very safe and very effective for asthma. Would a steroid help with this? Maybe it would, because we know an injectable steroid like Decadron helps for the sickest patients who have COVID. And so it's not totally unreasonable to think about it. So budesonide and dexamethasone are not that different. So you could see how it might help. And early on in anything, the way people learn things is through observation and trial and error. So you will recognize that, vaccination comes from vaccinia, which is cowpox. And the way this all started was that a very, very smart person recognized that that milkmaids rarely got bad smallpox. And it was like, why should milkmaids not get it? When they looked carefully, it was milkmaids who got something called cowpox from milking cows seemed to be immune from smallpox. So what Jenner did is took some of the vaccinia, put it in somebody else, called it a vaccination, and it really did seem to protect against smallpox. So that's how we learn things, is through careful observation and trial. And so that this guy noticed this is perfectly good. But the next case on this is then to actually check it out, right? To actually do a study to see if it works. Because every week there's somebody comes up with, this is the new latest and greatest for this. And I follow it for a week or two, and then it comes out, they tried it, it really didn't work. I have looked to see if anybody else is using budesonide. I can't find anybody else. There was a paper that came out 2 weeks ago that looked at budesonide and didn't looked at inhaled corticosteroids and didn't think they worked. And there's potentially some risk. There's the study that showed that Decadron worked for hospitalized patients also showed that if you use it for patients who was less sick, it didn't help and may have hurt. So there's a little thing there. So what should we do? So what we should do is, this guy thinks budesonide works, so we should come up with a protocol. Person comes in the hospital, and we say to you, hey, we got budesonide. Do you want to try it? They try it, and then you compare it with somebody who didn't get budesonide and see if there's a difference. Now, I'm a little leery of this. This guy says it's 100% works right away. I've been doing this a long time. There is nothing in medicine that works 100% right away. I mean, just nothing. Antibiotics are pretty good, antivirals are pretty good, but nothing works 100% after the first treatment. So it's a little skeptical. I'm also a little skeptical because he published this he did this YouTube video at least 3 weeks ago, maybe as much as 6 weeks ago, and still hasn't published it, right? I mean, if it was this good, you'd write a letter to the New England Journal saying, I tried 58 patients and I gave them this, and within an hour they all got better, and then other people would be able to look at it, and we haven't done that. So I don't know about budesonide. My fondest hope is that somebody does the study. It wouldn't take long to do, right? If it was that good, you'd only have to do 30 patients before you saw that the 15 patients you didn't treat followed the typical course, and the 15 patients you did treat were all magically better. Now, here's a concern. I saw this today. I looked at Odessa, Texas, and just exactly the same outcomes with COVID as everyone else. So this guy in Odessa and his ED guys were using this, and it was so great, you would expect that they would do much better. They didn't. And the other thing is, you would expect that other people would say, yeah, I tried it, and it really worked. So I don't know. So I'm still wanting to see. This goes in the pile with hydroxychloroquine, which was touted by this doctor in upstate New York, azithromycin by a doctor by several doctors, not using ibuprofen, which was touted by a doctor in France, Pepsid, which was touted by a doctor in New York, and there's a bunch of these here. None of the other ones have panned out. I really, really hope this one pans out, because this drug is cheap, effective, easy to use, but I don't think so. Yeah, so Patty says, I know someone who did a self-test, others that only went in an inch, and some that went in 5 inches, some took 20 minutes, some take an hour, some take days. Yeah, there's all kinds of different tests out there. They all have different sensitivities and specificities, turnaround times, and availability. So, for example, on the Abbott test, you can do it from the anterior nose, and you get the results in 20 minutes. Those tests are really, 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 really hard to come by, and they're not terribly accurate. The most accurate test we think out there that you can do is the deep nasal swab sent to a big lab like LabCorp, Quest, or OHSU. And so there's trade-offs on all of these. The goal would be to have a simple, easy, inexpensive, very sensitive and specific test that everybody could have. And you'll remember, for those who are making up their Christmas list, what I wanted for Christmas this year was a home saliva test that I could spit in, take my shower, and look and say, I'm good to go. And if everybody could do that, then we would be good to go. We'd get rid of this in 2 weeks. That, they're actually getting closer to that. Maybe not in time for Christmas. Okay, we were getting close here, and I want to go with our one special thing. Yeah, so somebody says they're tired of hearing about underlying health conditions. Yeah, I hear you. I mean, we're doing this so that we can understand about what the risk factors are. But you know, by the time you get to be 40, who among us doesn't have risk factors? So my wife and I had this discussion, and she said, well, I hope my ankle pain isn't considered an underlying health condition if I get this, or I hope that, a little bit of blood pressure that you have, or baldness is not considered a condition, underlying health condition. Yeah, I think we put them in there, but I don't pay much attention, because if you're 60 and have high blood pressure, if you're 58 and don't have nothing, or 70 and have underlying health conditions, who cares? It's still a person who died. These are not people, for the most part, who were on death's door and they were going to die anyway, and the COVID accelerated their death by a week or two. Most of these people were young and healthy. I mean, think of the Diamond Princess. These were people who were well enough to do an international cruise. It's not like these were people on death's door. These were vibrant people. Yeah, so Leslie says, can you explain the difference between droplets going out of a mask to infect someone and coming from somewhere else? So if you've ever squirted a hose, what you know is that when it leaves the nozzle, the droplets are quite large, and by the time it gets out there, they really get very small. And similarly, when you cough or sneeze, the droplets are quite big at your mouth and then get smaller. So not surprisingly, it's more protection on the place where it's leaving than the place where it's getting there. We think now that there's maybe slight protection for the wearer of the mask from getting the disease, but we know that there's a lot of protection from the person who is pre-symptomatic, and the CDC suggested that pre-symptomatic people do spread it, that this helps to prevent pre-symptomatic spread. So again, I don't know that I'm not coming down with this in 2 days, and if I'm coming down with this in 2 days, I certainly don't want to infect the people around me. Yeah, so Sandra says, will those who have tested positive need to be vaccinated? I don't know the answer to that, so we'll see. Okay, so Amber says, now that testing is widely available, is that the reason for the increase in cases? And the answer is it's a reason for a slight increase in cases. So when we look at the cases that are increased, about 10 or 15% of the increase in cases is due to increased testing. The rest of it, 85 or 90%, is due to increased transmission. So yes, as you test more, you'll find more cases. But if there weren't more cases out there, what would happen is you test more, the number of cases would go up slightly, but the testing positivity rate would go way down, which is exactly what happened in countries as they got near the end of this, is that they did more and more testing, they found more cases, but the positivity rate went down to 20%, 10%, 5%, 1%, and they got down to 0.1%. Our testing positivity rate is going way up, suggesting that, yeah, you may be finding more cases as you're doing more testing, but also there's a lot more disease out there. Yeah, is this the second wave, or the first wavelet and the second spike, or the second wave, or really the third wave? I don't know what you call it. I think that's all semantics. Clearly what we saw was a peak early on. We had a lessening of disease and then another peak. So whether that's the end of the first wave or the beginning of the second wave, I don't know. So is there mandatory isolation for people coming from other states with high rates? Oregon has not done that yet. Hawaii does that. New Zealand does that. So if you come from another state, you either had to have a negative test or quarantine. Australia does it even for people who are from Australia. So New York has talked about it. Oregon has not done that yet. It would be really hard to do in Oregon. Many of the people come to Oregon come on the roads. Unlike Hawaii, where most people come by air, Alaska, most people come by air, easier to enforce, really hard to enforce in Oregon, unless you're going to have border checks, and we're not there yet. So Fred says, I heard the governor, is releasing inmates to counties of origin and putting them in hotels. Is this true? Are you notified of where and when? So the story is that people who are in prison get released. Many of the prisons or correctional facilities have had cases. So yes, there are people being released from correctional facilities who either have the disease or have been contacts of the disease. This has been happening since the beginning of the pandemic. Yes, some of them are living with their parents or friends or neighbors, and we're monitoring them. Some don't have a place to live and are living in hotels or motels. And yes, that's the case. We know exactly who these people are. For the most part, they've been negative. We've had, I think, one positive. Most of them have been negative. We don't think any of them have spread the disease to anybody else. Thoughts on fall sports? I miss football. I don't know what's going to happen with fall sports. There was somebody who said today that if you tried to create a sport where you would spread droplets, it would be called football. These guys are on the line. They're right next to each other. They're jawing at each other. They're looking at each other. They're tackling into each other. Clearly, they're spreading germs. And so football is going to be really, really hard to do. The other thing we've seen is that as college teams have gotten together, they have a really high rate of underlying disease. I don't know what's going to happen with football. I think some fall sports are going to happen. I think cross country is going to be there. I think soccer probably will be there. Don't know what's going to happen with football. Don't know what's going to happen with volleyball, but we'll see. Okay, 7 o'clock, time to go. So, a couple things. We get every day, we put out a report, we get every day a comment. You should include this, you should include that, you shouldn't do this, you should call it this, you should call it that. So this is the report challenge. So what I'm asking people to do is to come up with the perfect report and put it in a Word document. And the perfect report has to say everything you would want in it. It needs to be a level that could be read by the public. It could have data that we know the answer to, right? Because some people would want to know something like somebody's deepest, darkest thoughts. We don't know that. But what they would want to know, and I would like, and you won't know this exact data, but given the kind of reports we do, the exact information you would want. And I would have you do that, put it in a Word document, and mail it to mail@douglaspublichealthnetwork.org. That's mail, M-A-I-L, at douglaspublichealthnetwork.org. Easier said than done. Easier done than said. So anyway, so do that if you can. And I'll look at those. And at one of our next things, we'll get advice from people on how to do it. The problem is that we get all this advice. It's all discordant advice. Some people say we should be doing more. Some people do less. We should include things, not include other things. And so put it out there. Somebody out there may have a much better idea on how to do this data, and we'll do it. So again, that's mail@douglaspublichealthnetwork.org. And again, a Word document and exactly what you want on it. Please don't use public health terms like infection fatality rate, mortality rate, or whatever. Use in plain English like the number of people that died or the number of people who are infectious, or in general terms, because what we find is that when people use public health terms, they frequently use them a little differently from what we need. So put that in there, send it to me, we'll look. Now I will tell you that over the last 2 months, I've asked a number of people to do just this. I said, well, look, you seem to have a really clear view of what you want to see. Could you put that out in writing for me? And I haven't gotten much response to it. So now I'm hoping we get a lot of response. So once we get half a dozen or so, we'll put those together and we'll look to see what the reports would look like. So you can get exactly the report that you want. Couple of things. The last thing we'll talk about, then we'll go, was about the number of recovered. Again, we've talked about this before. Remember, about the beginning of the month, there was a change in the definition of recovered. It used to be the same as the end of isolation, and now it's 60 days after the disease. I looked, computing in the two different ways, And it really doesn't make any sense doing it because we were up to 34 recovered. But if you use now the new definition, it would go down to 24 and would stay at 24, 25 for the next week because it would reflect the number of cases we had 2 months ago in May, which was only 24, 25 a day. So a 24, 25 total, and we remember we went weeks at a time without adding a case, so our recovered would look just the same. If what you're really wanting to know, and I think what people are wanting to know, are how many people are no longer infectious, you can get that number. You take the total number, you subtract the number in isolation. That's the number that we previously used as recovered. So again, the total number minus the number in isolation, that gets you a number very close, not exactly, but very close to the number that we previously used for recovery. Okay, thanks for that. And again, the challenge, come up with the perfect report and send it to mail@douglaspublichealthnetwork.org. Again, this is Dr. Bob Dannenhoffer, Public Health Officer from Douglas County. It's July 14th. We'll see you again on Friday. Thanks.